Hello?
Hey, Dr. DeShano, it's Training Division.
Yeah.
Hey, I wonder if you could, Bob Marshall and Chief Branham here and Officer Godby, I wonder if you could give us some tips on contacting you and the things that you're looking for as benchmarks from the field.
Okay, sure. Well, I mean, obviously the reasons that you have to call are fairly limited, and in general they're fairly focused, unless you've just got a generic consult that you're confused by a situation or something. And those are kind of broken down into two pieces. The ones that are focused, you just need to paint the picture, the patient history, the vitals, the physical exam, and what you're looking for. The second type, where you're just a little perplexed by the case and all, is more complicated. You need to give a little bit more detail about the patient's presentation, the reason for the 911 call, who called, what type of a setting you're in, and then just summarize your assessment, the history, the physical, past medical history, medications, allergies, your vital signs, what you've gotten, and then perhaps one or two ideas as to where you're headed, what you think is going on. The key to it all is about painting a picture, because I'm not there to actually see the patient, and I've got to have a way to get a good picture in my mind of what's going on. Whether or not you're in, for example, a nursing home versus the middle of the street makes a huge difference. Or if you're in the patient's home with hysterical relatives around, or perhaps the perpetrator of a crime, it's really important to paint as good a picture as you can to help me feel like I'm there.
So really focusing in on your good physical exam, giving you all the things that I can see, and then certainly if I have some intuition as to where that patient's condition is going or what's his presentation, helps paint a better picture for you.
Yeah, absolutely. I mean, even if you're a little unconfident about what your opinion is, always give your opinion. The worst thing that can happen is you're wrong. But what I found more often than not, and I come from a paramedic firefighter background, is that you may have an idea from what you've seen around the scene that I might not have even thought of, because I'm pretty much blind by sitting at home or sitting in the office talking to you, whereas you're there with not only just the sights and sounds, but the smells and the passing views and all that. So yeah, giving your opinion is always important.
Well, I appreciate it, Dr. DeShano. If I could ask one last question. For the new paramedic that is on the job, who may not have a complete understanding of sometimes the complex verbiage that we occasionally speak to one another, is it just adequate for you if they just slow down and give you just a good size up and what they think, not necessarily in the exact hows and whys and the perfect medical vernacular, but just painting the picture? Would you say that is just adequate?
Oh, yeah, absolutely. They need to, I mean, painting the picture doesn't require big words. Painting the picture requires a lot of small words, basically. And, they just need to be comfortable in how they're describing it to me. I mean, in a lot of cases in the past, I've been the person on the scene, so I know what scenes look like. But because I'm not there now, even if they were in my position, they would want a good description of what it looks like, what it sounds like, what it smells like, to give you an idea of what the scene is actually like. Beginning with things like scene safety and going on to transport method. It's all important. It just needs to be described. It doesn't have to be described with big words.
Great. Thanks a lot, Dr. DeShano, for your time today.
No problem. I'll talk to you later.
Bye-bye.
Thanks. Hello?
Hello, Dr. DeShano. This is Bob Marshall.
Yes.
Hi, I want to request some orders. I have a patient who's a 45-year-old hypoglycemic. Upon our initial arrival, he had a Glasgow coma scale of 3, basically unconscious, unresponsive. We've started an IV and given him 2 rounds, a half an amp, and then repeated that. repeated our glucose about 10 minutes after that, and we found that it came up to 70, but he's still somewhat confused and aroused easily, but not fully awake and alert. I'd like to get a second dose or a half an amp up to a full amp afterwards, PRN, until the patient's awake and alert. Is that okay with you, sir?
Well, okay, what was his initial finger stick?
His initial AccuCheck was 31.
And the repeat, you said, was 70?
Repeat was 70 after giving him 2 half doses, or a total of 25 grams.
Okay, so he went ahead and woke up, but he's still confused.
Yes, sir. And I understand from the family he has a long history of diabetes, and sometimes it takes him a little while to wake up.
That's exactly what I was just going to ask. Yeah, go ahead with the additional 2 1/2 doses and repeat an AccuCheck in about 5 minutes after that and see what that does for you.
Okay, thank you, sir. I appreciate it.
You're welcome. Bye.
All right.
Hello?
Hi, doctor.
Yes.
Hi, this is Paul Costello on Rescue 74. I need some Medic 1 orders.
Okay.
We're on scene of a drug overdose, we think. He's 20 years old, and he's kind of a frequent flyer. We see him. He uses heroin and a lot of other stuff, polypharmacology. His vital signs are his pulse rate is 80 and kind of thready. What's his blood pressure?
100 by PAL.
His blood pressure is 100 by PAL, and we're assisting his ventilations with a BVM, and his SAT's 95. We gave him half an amp of D50 first, and his AccuCheck was 90. Was that before we gave it?
That was before.
Before. We want to give him some Narcan, but we think he needs a little bit more. We'd like to give 10 milligrams of Narcan.
Yeah, I mean, I agree he's probably going to need more. A couple of questions. Is he protecting his airway even though you're assisting him?
He has a gag reflex.
He has a gag, and he hasn't puked.
Okay. Are you in your district, so you're close to UCH?
Yeah, we're a couple miles away.
Okay. Yeah, as long as he's protecting his airway, I think I would continue to assist him as needed. Go ahead and give him a fluid bolus. And I don't think I would give that much Narcan. If you want to try, I mean, the question is, if he's protecting his airway, the outcome may be either violent vomiting or violence towards you. So, I mean, if you want to try 2 milligrams of Narcan, I would go ahead and do that. But if you don't need to, I'd probably just hold off. Because, like I say, you may be getting into things you don't want to get into this close to the hospital.
Okay. All right.
So, I mean, like I said, the biggest thing is to keep him protecting his airway. And as long as he's doing that, I would keep the Narcan dose either absent or to a minimum.
Okay. I appreciate it. Thank you.
All right, so go ahead and do that, and if you need anything else, call me back.
Will do.
All right, thanks.
Bye.
Hello?
Dr. Dushano.
Yes,
Yes, hi, this is Christine Brannon from Hillsborough County Fire Rescue. How you doing, sir?
I'm good. How are you?
Good. I'm calling in regards to a patient I have at this time. I have a 62-year-old male in full cardiac arrest, downtime of about 10 minutes prior to our arrival. We've done 25 minutes of ACLS, advanced airways in place. We've ruled out all our H's and T's. We've got a king tube in place. IV has been established within the right external jugular. Patient has been asystolic throughout. He's got an end-tidal CO2 with good CPR of about 9. We spoke with a family member, and we are requesting field termination at this time, doctor.
Okay, and what kind of facility are you in? What kind of setting?
We're at the residence of the patient.
Okay, and the family member, is the family member that's there a decision maker, do we know?
Yes.
Okay, and the family, so no one is in disagreement with the termination? Everybody's on the same page?
Yes, sir.
Okay, after that amount of time, how many epi and atropine total?
I've given a total of 4 epis. Patient has been asystolic, and we don't give atropine anymore for asystole.
Right. Okay, yeah, that sounds appropriate. I would go ahead and terminate.
Okay, thank you, doctor.
All right, you're welcome.
Okay, bye-bye.